I would like to introduce Dr. Giacomo Gracelli. He is an associate professor of anesthesia and intensive care medicine at the University of Milan. He's also director of a Milan hospital, and he will talk about non-invasive ventilation.
Good morning. My name is Giacomo Gracelli from the University of Milan and the Ospedale Policlinico Hospital in Milan. I am an intensivist, and I'm here to try to explain you the basic principles of non-invasive respiratory support for patients with acute hypoxemic respiratory failure with COVID-19. So these are my conflicts of interest. I'm sure that you have already seen a similar slide in the previous presentations. We subdivide non-invasive forms of support in standard oxygen therapy, which goes from low flow oxygen, Venturi mask, bag mask, and nasal high flow. And these have been treated, I think, in the previous presentation, while the focus of our presentation is what we call non-invasive ventilation, which is a broad term that encompasses two entities. One is continuous positive airway pressure, and the other one is non-invasive positive pressure ventilation. And we will see what this means. First of all, I want to show you the recommendations on the use of non-invasive ventilation issued by the European Respiratory Society and the American Thoracic Society very recently. As you can see, non-invasive ventilation is highly recommended with a very high level of evidence in hypercapnic respiratory failure and in cardiogenic pulmonary edema. Then there are other recommendations and other indications, while the ones we want to talk about today, which is de novo hypoxemic respiratory failure and pandemic viral illnesses, basically have no recommendation. And why is this? Because the use of non-invasive ventilation techniques in the management of acute hypoxemic respiratory failure is still debated. And it is debated because there are conflicting literature data, because as we will see in details later, when we treat a patient with severe hypoxemia with non-invasive ventilation, the risk of failure is quite high. We know that the risk of failure is higher in more severe patients, so in patients with ARDS, with very low PF ratio, which means very severe hypoxemia, with multiple organ failure. And these are the typical COVID-19 patients. And what we also know is that if we recognize too late failure, and if we intubate the patients too late, then the patients will die more. So this is why the task force of ERS and ATS together were not able to issue a recommendation in favor of the use of non-invasive ventilation in acute hypoxemic patients. So this is what we will talk about today, as I told you. So we will see first continuous positive airway pressure and then non-invasive positive pressure ventilation. So what is continuous positive airway pressure? So during physiological breathing, the pressure within in our airways keeps changing. It is negative during inspiration when we pull air into the lungs, and it goes back to atmospheric pressure at end expiration. So by convention, by definition, atmospheric pressure is zero. So during inspiration, our respiratory muscles produce usually a negative pressure of -4, -5 centimeters of water. And then when the air is exhaled, at end expiration, the pressure in the airways becomes equal to atmospheric pressure. So Cpap is a form of support where a certain level of positive pressure is applied at the airways so that at end expiration, the system does not go back to atmospheric pressure, but it goes back to a higher pressure. So basically, during CPAP, the pressure in the airways remains positive throughout the entire respiratory cycle. And the positive pressure which is applied at end expiration is called PEEP, positive end expiratory pressure. So on the left-hand side, you can see what happens during spontaneous breathing. As you can see, airway pressure, spontaneous unassisted breathing, airway pressure oscillates around atmospheric pressure, which is 0. So it's negative during inspiration and basically goes back to 0 during expiration. During CPAP, as you can see, airway pressure oscillates but remains above atmospheric pressure. And why do we want to apply positive pressure at end expiration? Because if you think of the lung like a balloon, when you inflate the balloon, then when the balloon deflates, if it does not deflate, if it does not go back to atmospheric pressure, but you keep some pressure within the balloon will not deflate completely. So this means that if we apply some pressure into an elastic system, then this system will have an increase in volume. So the idea is to open up the lung, which is collapsed by the pneumonia, to increase end expiratory lung volume or functional residual capacity. So basically, it's a way to increase pulmonary volume, so to increase the pulmonary surface that can be used for gas exchange. So what is very, very important to know is that during CPAP, the patient breathes without assist. So we only apply a certain level of PEEP, but the patient and his muscles are doing the entire work of breathing. And what is also very important is that CPAP can be applied without a mechanical ventilator. This is a study very simple, and as you can see, when we apply increasing level of PEEP with different interfaces, and we'll see it later, you can see that the volume, lung volume at end expiration, functional residual capacity or end expiratory lung volume increases with increasing level of PEEP. So the higher the PEEP level we apply, the larger will be the increase in lung volume, so the better will be the effect on oxygenation. Okay, so to apply CPAP to the patient, we need a source of oxygen, a high flow source of oxygen, and we will see it. Then we need an interface to connect the oxygen to the patient. And usually we can do CPAP with an interface, which is the helmet or a face mask. And then we need a valve on the expiratory port of the interface, which introduces a resistance and generates the positive pressure applied at the airways. So when we apply CPAP, we want to keep airway pressure as more stable as possible. Clearly, as we have seen, the airway pressure will oscillate around the PEEP level, but we want to keep as stable as possible the PEEP level. We need a source of high flow fresh gas, and the main problems are that we consume a lot of oxygen, that we need to humidify, if possible, the air-oxygen mixture that the patient is breathing. And then clearly, when we apply a positive airway pressure, when we apply an expiratory resistance, we can have a problem of expiratory workload, but this is a detail, okay? This is very, very important. When we apply fresh flow CPAP with the helmet, the gas flow within the helmet must be always higher than 30 liters per minute. And this is because if the flow is lower, we will have CO2 rebreathing. So to avoid CO2 rebreathing, to avoid the rebreathing of CO2 exhaled by the patient, we need in the helmet a high fresh gas flow which washes out the CO2. And another important concept is that if we want to apply Cpap with the helmet, we need a fresh gas flow. The ventilator is not a good source of gas flow. The mechanical ventilator is not a good source of gas flow to provide Cpap with the helmet. Again, because of the risk of CO2 rebreathing. So this is a helmet, as you can see. And which are the advantages of the helmet? Clearly, if there is a good seal around the neck, there will be limited problems of air leaks. It does not cause abrasions on the skin lesions. It grants a stable level of PEEP and, very important, a stable level of FiO2. So using the helmet with pure oxygen is the best way to give pure oxygen to the patient. It's like an oxygen tent sealed around the patient neck. There are clear disadvantages. We have seen it, the risk of CO2 rebreathing, the risk of disconnection of the helmet. And so now all the helmets have safety valves that avoid that the helmet collapses on the face of the patient if it accidentally disconnects from the gas flow, from the gas source. There is noise within the helmet, and modern helmets have, again, like tools to reduce the noise. There is the risk of claustrophobia. Some patients do not tolerate the helmet, while others tolerate it very well, even for hours. And in case you use the helmet as an interface for non-invasive ventilation with the ventilator, there is also the risk of asynchronous, but maybe this is a little bit too specific. There are also other devices to provide Cpap, fresh flow Cpap, with a face mask. This is called Ventumask. You can see here a flow meter, a double flow meter that gives enough oxygen. And then there is a Venturi valve that here, there is a Venturi valve that increases the flow through the system. And here there is the PEEP valve where we can adjust the level of end expiratory pressure. And the Venturi valve works exactly as a venturimeter. It means that you give oxygen from one flow meter, oxygen from the other flow meter, and the higher is the flow, the higher is the amount of airflow from the ambient. And this mixture goes to the patient. So this is the Venturi principle. Another useful tool to provide Cpap with a face mask is the Bussignac valve. So this is more like a portable device, and the advantage is it can be used with any normal tank of oxygen. So it doesn't need a double flow meter. Again, it works with the Venturi principle. The main disadvantages are, first, the high oxygen consumption. If we want to provide 10 centimeter water of PEEP, we need 24 liters per minute of oxygen. So if we use a regular tank, this will be empty very soon. And also, there is not a stable fraction of inspired oxygen because the FiO2 will decrease if the patient has labored breathing with increasing inspiratory effort. Which are the main contraindications? Cpap, patients who are apnoic, of course, patients in comatose or with some compromise of state of consciousness, so they are unable to protect the airways, so they are unable to cough, pneumothorax, and hemodynamic instability. So these are the main contraindications of Cpap. So the second technique is what is called non-invasive positive pressure ventilation. This needs a mechanical ventilator connected to the interface, which is connected to the patient. So during NIPPV, the ventilator applies a certain level of PEEP at end expiration, but then it also applies a certain level of positive pressure above PEEP during inspiration. So basically, the ventilator pushes air into the airways during the inspiratory phase and then keeps a stable PEEP level at end expiration. So in this case, the ventilator provides a sort of assist to the patient. And the patient and the ventilator share the work of breathing. So there are basically two common modes. One, it's the most used is, more frequently used is pressure support ventilation. So again, the ventilator applies a certain PEEP level, and then when the patient breathes in, possibly synchronized with the inspiratory effort of the patient, the ventilator gives a certain level, a preset level of pressure assist, okay? So in this case, during pressure support ventilation, the respiratory rate is determined by the patient, because every time that the patient breathes in, the ventilator gives inspiratory positive pressure to assist the patient's effort, to assist the patient's muscle, to help the patient's muscles to do the work of breathing. There is also the other mode, it's called bilevel of pressure control. So again, the ventilator cycles between two preset positive pressure levels, one at end expiration, PEEP, one at end inspiration, positive inspiratory pressure, at a fixed rate. So the rate is set by the doctor, is determined by the machine, and of fixed duration. So this is a more mechanical form of ventilation. So not necessarily it is synchronized with the patient effort. So non-invasive positive pressure ventilation, again, needs a mechanical ventilator. It can be performed with the helmet, but the best interface are face masks. And as you can see, there are different models of face masks that cover nose and mouth, or even total face masks, like in this case. Clearly, if you have to keep the face mask for a long period of time, stick on your face, you may have problems like claustrophobia again, but the most important are skin and mucosal lesions, as you can see here. Clearly, the patient has problems in speaking and coughing, much more than with the helmet. And again, if the patient vomits, there is a risk of inhalational pneumonia. The contraindications, again, are depressed state of consciousness and coma, inability to manage secretions, again, hemodynamic instability and shock, and the relative contraindication are gastroenteric bleeding, recent upper gastroenteric surgery, and of course, problems in the device positioning, intolerance, because the mask applies a certain pressure on the face, because the most important thing is that the patient and the ventilator must interact within each other. They have to be synchronized, and these can be obtained only by reaching a good seal of the face, of the mask around the face of the patient. So sometimes you need to tighten up a lot of the straps in order to avoid the leaks. And that's the most important, and that is the most important and most tricky point of non-invasive positive pressure ventilation. Avoiding the leaks, the air leaks, so that the interaction between the patient and the ventilator is acceptable, so that the ventilator understands when the patient is breathing in order to give him inspiratory assist synchronized with his breathing efforts. So this is basically a table that in some way summarizes the main differences between CPAP and pressure support ventilation. As you can see, with pressure support ventilation, respiratory muscle unloading is much more effective. Both grant a certain level of hemodynamic support, especially in patients with left heart failure. Both are very effective in improving oxygenation. With pressure support ventilation and the ventilator, there is the problem of patient-ventilator interaction, which is basically does not exist during CPAP. CPAP, especially with the helmet, can be applied for longer periods, and also CPAP needs a shorter learning time for operators compared to non-invasive positive pressure ventilation. So why should we use non-invasive ventilation in COVID-19? Well, because we know that in patients with acute hypoxemic respiratory failure, non-invasive ventilation, any form of non-invasive ventilation, I mean CPAP and IPPV, are superior to standard oxygen, as demonstrated by this very recent meta-analysis published in JAMA that demonstrates a significant advantage in both in mortality and the intubation rate for an IPPV and CPAP compared to standard oxygen. Then we use non-invasive ventilation because we do not need to sedate the patient too much, while if we have to intubate them and connect them to a ventilator with an endotracheal tube, clearly we need to have patients deeply sedated. We know that non-invasive ventilation, if it succeeds, is associated with improved outcome, and very important, during a pandemic outbreak where there is a shortage of beds, non-invasive ventilation can be applied outside the ICU. And this is why the recent guidelines of the Surviving Sepsis campaign suggest a trial of nasal high flow or non-invasive positive pressure ventilation in all patients who do not need immediate intubation. So which are the risks of the non-invasive approach in these patients? The first one is the risk of failure and delayed intubation. So we know from the literature that in patients with acute hypoxemic respiratory failure, the risk of failure with non-invasive ventilation is very high, around 40% or even higher. And we know that patients who fail non-invasive ventilation have higher mortality. So NIV failure can be immediate, can be early or late, and in this paper, the conditions associated with immediate and early failure are described, but basically we know that patients with more severe hypoxemia and patients with more severe, with higher baseline scores, and patients with ARDS have a higher risk of failure. So COVID-19 patients theoretically are at higher risk of failure with non-invasive ventilation. So it's extremely important to monitor the patients. And so how should we monitor the patient? We have to do clinical evaluation, monitor vital signs, monitor heart rate, blood pressure, EKG, oxygen saturation, and of course, gas exchange with repeated blood gas analysis and lactates. So this is the basic monitoring that should be implemented in every patient during non-invasive ventilation trial for severe hypoxemia. And the clinical evaluation is based on vital signs, blood pressure, heart rate, respiratory rate is extremely important. It's very important to evaluate the mental status of the patient, agitation or drowsiness, the skin changes. So these are all signs that should be recorded on the patient chart. And which are the signs that are very ominous, that we have to pay a lot of attention? The signs of respiratory distress, so very high respiratory rate, use of accessory muscles like intercostal muscle use, hypocapnia, which is a sign of high respiratory drive, and failure to improve hypoxemia after the application of non-invasive ventilation. Clearly, signs of exhaustion, hypercapnia, deteriorating mental status, Hemodynamic instability and acidosis are always bad signs, and clearly signs of upper airway obstruction. In presence of all these signs, you better call for help. We can predict NIV failure. For example, this course takes into account heart rate, acidosis, consciousness, oxygenation, and respiratory rate. So as you can see, all the parameters I told you before. And when this score is above 5, 1 hour after NIV application, then it's highly predictive of failure. The second problem with NIV is that when the patient has a very high respiratory drive, it breathes a lot. So it generates high volumes and high pressure, and this can destroy the lung, what is called patient self-inflicted lung injury. The third problem, which is very important during outbreaks of infectious disease, is the risk of environmental contamination and transmission of the disease to the operators. So we know that NIV and physiotherapy are droplets, not aerosols generating procedures, and the droplets fall within 1 meter of the patient. It's been demonstrated that dispersion during nasal high flow and Cpap is limited and is negligible during face mask Cpap. Also, it's been demonstrated that the air dispersion is higher during NIV with face mask than during NIV with the helmet. And then the helmet, if it has a good seal, is probably a very good interface to avoid environmental contamination. And also, with the helmet, you have the advantage that you can apply an antiviral filter at the outlet port of the device. And this is a recent paper that studies the maximum exhaled air distance with different models of masks commonly used for non-invasive ventilation. And the last slide is that I remind you that there is a lot of interest and several reports of the use of prone positioning in non-intubated patients. So in patients during helmet Cpap or during non-invasive positive pressure ventilation or during nasal high flow. For prone positioning, you will heard it in another lecture, but prone positioning basically redistributes ventilation and blood flow to the lung, helping us to reach more favorable VQ distribution and improving oxygenation. So we do not know the impact of prone positioning in non-intubated patients on the outcome of non-intubated patients, but we know that putting the patients prone is associated with an increase in improvement in oxygenation. So basically, what we know is that patients with COVID-19 and acute respiratory failure who fail standard oxygen and who do not need immediate intubation are a good candidate to a trial of non-invasive ventilation. We've seen that helmet Cpap, helmet is an effective way to provide non-invasive Cpap. And if we have to provide Cpap, helmet may be preferred because it's associated with improved patient comfort and reduced risk of environmental contamination, while non-invasive positive pressure ventilation may be preferred, preferably with a face mask, in patients who need unloading of the respiratory muscles. But the most important message of this talk is that if you apply non-invasive form of support to patients with acute respiratory failure, you need to be very carefully monitoring the patients. So patients must be monitored continuously for risks of failure, and in this case, you have to call the intensivist and proceed to intubation if necessary. Thank you very much for the attention.
Thank you, Professor Grasselli. You have taught us that the indications for non-invasive ventilation are hypercapnia and hypoxemia. But we should be aware to delay intubation because this increases mortality, and particularly in areas so in COVID patients. So this is, but at the same time, you recommend a trial. And yeah, my question is, you explained the CPAP and the non-invasive positive pressure mode. To me, it seems that providing or unloading the work of breathing with the use of pressure support would be superior in ARDS. But what is your idea of which mode is the best for the COVID ARDS?
Well, you know, in Italy, we really like helmet CPAP. So in our experience, for example, like 70% of the patients that we have managed outside the ICU with non-invasive support have been on helmet CPAP. And we had a failure rate of around 35, 36%. Basically, what I think is that in hypoxemic patients, what's really important is to increase the mean airway pressure. So CPAP is a very good mode because you increase positive airway pressure, so you basically expand the lung, but that since you have a fresh gas flow, this is sometimes more comfortable for the patient. The non-positive pressure ventilation is more useful when the patient is hypercapnic because you want to increase the mean ventilation to remove CO2, and also when the patient is going towards exhaustion, so when you need assist to the respiratory muscle to reduce the work rate. But in patients, in severely hypoxemic patients with a very high respiratory drive, it may be very difficult to synchronize the patient and the ventilator. If a patient has like 40 breaths per minute of respiratory rate, and there are maybe leaks in the system, then the ventilator, it will be very difficult for the ventilator to follow the patient. So I think that for purely hypoxemic patients, like patients with acute pulmonary edema or pneumonia, ARDS, my first approach would be CPAP. It's easier, you don't need the ventilator, you just need a fresh gas flow source. You can do it with the helmet, with the mask. The helmet is probably advantageous if you want to keep it for prolonged period of time, but I know that the helmet is very popular in Italy and not so popular around the world. So, face mask CPAP is very good too. To me, if the patient is purely hypoxemic, I would start with CPAP, and then maybe I would do a trial of non-invasive positive pressure ventilation. If I understand well, this course is meant for non-intensivist, and non-invasive positive pressure ventilation is probably one of the most difficult things to apply, even in the ICU, because you have to know very well the ventilator, you have to know how to apply the mask, how to reduce, how to set the ventilator. So it's, I mean, it's a tricky technique. I would say that CPAP is much easier to learn. And you provide oxygen, and you provide a certain level of positive airway pressure, yes, which is what you need in case of hypoxemia.
Thank you, that is clear. Could you please tell us about your experience of the use of CPAP on the ward? As you just said that you have experience in Italy. Is it safe enough, or did you experience some crash intubations with cardiopulmonary resuscitation, so too late? Or
no,
what is your...
We use it commonly in the wards, even before this COVID-19 outbreak. And maybe the reason is that in Italy we have we didn't have enough ICU beds before the COVID-19 pandemic. You know, like in Italy, for example, in my region, which is Lombardy, the ICU beds is around 2.8, 2.9% of the total hospital beds. So clearly, in the end, you admit to the ICU, 80% of the patients who are admitted to the ICU are intubated. And so we commonly apply CPAP outside the ICU. And I have to say that if you can monitor the patients, if the nurses are trained, and with the new helmets that have these safety valves, which protects against suffocating if the helmet disconnects from the gas source. I would say that it's quite safe and much more easy to apply compared to non-invasive positive pressure ventilation with a ventilator. In COVID-19 patients, I can tell you, we did a one-day prevalence study with Giacomo Bellani. On that day, we had in 30 hospitals 900 patients on non-invasive ventilation. 70% of them were on Cpap, all outside the ICU.
Thank you for that. I get a signal that we need to end this, but I think you make a very clear message that you have effectively used the Cpap in COVID-19 patients. Thanks a lot for your experience and your talk, Professor Grasselli. Goodbye.
Goodbye. Thank you.